Welcome back to The Explainer. We are jumping right into part 88 of our CPC exam practice masterclass today, and we're tackling high-yield pathology and lab case studies. Make sure to like, share, and subscribe to Decode Healthcare with Harshal.
You know, pathology and laboratory questions might make up only a smaller percentage of your actual exam, but man, they are absolutely notorious for testing hyper-specific precision rules. Today, we're officially transitioning from basic theory to solving high-yield scenario dissections, right under timed CPC exam conditions. We are going to expose the exact traps that catch even the most experienced coders off guard. So here is our roadmap for today. We are going to conquer 4 specific traps: the panel trap, specimen grading, drug screens, and modifier 91.
All right, let's dive into number 1, the panel trap, and the all-or-nothing rule.
Picture this scenario. A physician orders a comprehensive metabolic panel. That's code 80053. The lab successfully runs 13 of the 14 required components, but unfortunately, the serum calcium test fails and isn't reported. Now, the exam is absolutely going to try to trick you into appending modifier 52 for reduced service. It looks super tempting, right? But you cannot do this on panels. A panel code represents a rigorously defined exact set of tests. So here is the golden rule you need to remember. Panels are strictly all or nothing. If even a single component is missing, modifier 52 is never, ever permitted. Instead, you've got to build the performed tests individually or drop down to a basic metabolic panel, code 80048, and just add those extra tests separately.
Moving right along to trap number 2, specimen grading and surgical path dissection.
Imagine you're evaluating 4 completely distinct specimens submitted from a single surgical session. Surgical pathology leveling isn't guesswork. It has to precisely align with the tissue complexity. For example, a routine skin punch biopsy maps straight to a level 4, which is code 88305. A gallbladder excised for chronic cholecystitis, that's a level 3. Now, a more complex uterus with bilateral ovaries jumps up to a level 5. Meanwhile, something simple like a vas deferens for sterilization is just a level 2.
The massive takeaway here is that multiple distinct specimens from a single patient must always be reported individually. Seriously, don't bundle them into a single higher-level code. You have to treat every single specimen as its own distinct line item based entirely on its specific complexity. Okay, on to trap number 3, drug screens, specifically presumptive versus definitive.
Let's say a patient comes in for a routine pain management compliance screening. First up, an optical immunoassay test for the mere presence of opioids. This is your qualitative presumptive screen, code 8035. It's basically just asking, is the drug there? Because that result comes back positive, the lab then runs gas chromatography mass spectrometry to quantify the exact fentanyl and morphine levels. That is your definitive quantitative test, asking exactly how much is there. Because that initial presumptive test was positive, the lab runs the definitive confirmation test. And here's the secret to escaping this trap. You can actually report both, as long as they are medically necessary and properly documented. Don't let the exam trick you into choosing just one if the scenario clearly outlines the medical necessity for both a screen and a confirmation.
Finally, let's hit trap number 4, modifier 91, the repeat diagnostic test.
Check out this timeline for a diabetic patient in the ICU who's having their blood glucose tested multiple times to monitor their insulin response. You'd bill 82947 for the initial test at 8 a.m. Then, you report 82947 with modifier 91 attached for each subsequent clinical repeat, so at 12 p.m. and again at 4 p.m. on that exact same calendar day.
But here is the trap they love to set. Repeating a test because of a lab error, a mishandled specimen artifact, or an instrument malfunction can never, ever be billed with modifier 91. Modifier 91 is strictly there to monitor a patient's clinical condition, not to get paid twice because someone dropped a test tube.
So, here is your quick 1-page visual cheat sheet summarizing these 4 high-yield rules. Take a mental snapshot of this to immediately recognize and escape these exam traps. Remember, absolutely no modifier 52 on panels, always bill specimens individually, distinguish your drug screen methodologies, and only use modifier 91 for clinical necessity.
Join us next time for part 89 of our Explainer series, where we are going to completely crack the codes on the medicine section, specifically diving into immunizations, injections, infusions, and hydration therapy.
For now, review this masterclass. Practice these path and lab case studies until they literally become second nature. Then ask yourself, are you truly ready to conquer the CPT medicine section? Keep studying hard, and I'll see you in Part 89.